Okay, welcome everybody. I'm Dr. Shanti Kulkarni, and I'll be one of the co-presenters today along with my colleague, Dr. Kelly Powers. I'm just going to introduce myself real briefly, and then Kelly will kind of take over, and then we'll kind of tag team a little bit as we go through this presentation. So I'm a professor of social work, and the way I became involved in interprofessional education is through a HRSA grant that we were awarded about 4 years ago. And the purpose of this grant is really about training social workers to provide integrated behavioral health services within primary healthcare settings. And through that program, Kelly and I have begun to do a lot of collaboration around between nursing and social work, and also joined with other professions through the medical school. And we'll talk about that a little bit more as we get into the presentation. The other thing I want to just mention as part of context is this advancement towards interprofessional care is something that is coming from all of our professional bodies. So for example, the Council of Social Work Education now has competency standards around when we graduate students, we want them to have those competencies to work with other professionals, and that's all happening across the different professions like public health and nursing and medicine and pharmacy. And Kelly will talk about that as well. So welcome, and we're looking forward to spending this time with you.
Hi, everyone. My name is Kelly Powers. I'm an assistant professor in the School of Nursing at UNCC. And as Dr. Kulkarni said, we work together on a lot of interprofessional education initiatives, and it's grown into a passion for both of us. So we're excited to share this content with you and to stimulate some discussion around IPE and ways to move it forward. So we've been doing projects through the HRSA grant that Dr. Kulkarni's lead on, and we've published our work. We've done work on in trying to get interprofessional education in innovative ways, online, using simulations and all of that. And so we're excited to share what we've done, talk about IPE in general, and get the discussion going. So I'm going to share my screen now and get going. Can you see my screen? Okay, great. So the title of our presentation is Addressing Social Determinants of Health Through Interprofessional Education, which is also called IPE. So either one's going to come out of our mouths, just so you know. So IPE is interprofessional education. And we worked really hard on the design of this PowerPoint in making sure that it shows that as co-authors of it, co-presenters, that we're synergistic, collaboratively working together. And that's the representation of those circles there. There's no hierarchy. We collaborate to work together and bring you this presentation from a perspective of both of our professions, which is really key to successful interprofessional collaboration. So I need to move your heads. I'm sorry. There we go. Okay. So due to a variety of factors, the changes that we've seen explode in healthcare. We have increased acuity of patients, more chronic diseases, increased complexity of care. Couple that with fragmented systems and fragmented transitions of care, moving from one setting of healthcare to another, seeing multiple different specialists in all of these fragmented areas, along with a recognized need to address social determinants. Due to these factors, healthcare has to be performed by interprofessional teams. Current healthcare professionals must shift to a team-based care approach. And graduates, our graduates from undergraduate programs and graduate programs must be prepared to effectively work in teams. The problem is that despite knowing this, practice and education continues to occur largely in professional silos. So we're going to start off here with a poll. Wanting to know which of the following best describes your work site. So you should see a poll pop up. Okay, so the results show that really indicative of how healthcare is. Nobody selected one, saying that we work as just one profession in our site. So that's just not the way healthcare is now. Healthcare needs to be from a variety of angles and different professions, different perspectives, different um, specialty areas, different talents. So that's good. So that's consistent with what healthcare is now. But you can see here it's kind of split. Um, about half of you have persons from various professions, but mostly work independently and only consult each other when necessary. And the other half are going more towards the extreme of really doing shared decision making as a team, as an interprofessional team. So we have people here maybe wanting to learn more how the shared decision making can be implemented in their setting. And we have some people here who are already doing that, maybe want to share their expertise and even think of ways to do it better. So thank you for doing that. I'm going to move to the next slide. Maybe. And one more poll here, poll 2. We want to know how often interprofessional team-based care is practiced at your work site. So as a team, not just consulting. Great. So thank you, everybody. So a few rarely or don't practice. The majority of you sometimes practice this, and one of you usually practices this. So we're seeing that, we know interprofessional team-based care is good to do, but it's clear that we still have work to do within our work settings. And that's true for academia, that's true for practice, that's true all over, that we still continue to work in silos. We're getting better at approaching the team-based approach, but we're not quite there yet. We still have work to be done. I'm going to stop sharing this and move forward. So why do we need to focus on interprofessional team-based care? Well, the effects of continuing our siloed approach to care and education is that patient safety suffers. Right now, healthcare errors result in more than 250,000 deaths per year among adults in the United States alone. Prior to the pandemic, it was recognized as the third leading cause of death in the United States. The root cause of about 3/4 of these errors is communication failures within and among different teams. So different persons, different professionals within a team not having proper communication, and then not following through to the other team, and communication failures there too. And these figures are astonishing. Some reports quote that it's probably upwards of 400,000 deaths per year. And this is just deaths, not injuries, not adverse events. And it's also just focused, it's not focused on quality of care. If we don't have an interprofessional team-based approach, we're not going to have comprehensive care. And this results in inadequate care of the persons, families, and communities. So for example, if we use the medical model only, we're going to have missed opportunities for mental health and social care. Addressing the social determinants of health clearly requires a team-based approach. It cannot be a medical model only. We have to move it forward to have comprehensive teams to meet our patients' needs. If we don't do so, if we continue to have a lack of comprehensive care, if we have fragmented care, if we don't use a team approach, what happens is our patients, our communities, families, they experience things negatively. They experience healthcare negatively. They develop frustration, they develop mistrust, and what happens is they no longer access care, and we lose opportunities for prevention and improvement of health outcomes. So for example, if you are going into a clinic to be seen for whatever reason, and all of the different professionals approach you at different appointments, or they come in separately, and you have to repeat your story, maybe it's a traumatic story, you have to repeat it several times over and over, what happens in your head is you're like, well, this team's not communicating. This team isn't pulling it together. They don't know what they're doing. I'm not doing this anymore. And that's where we can see the breakdown in quality happen. Not just errors, but quality suffers and missed opportunities for really giving comprehensive care and improving health outcomes. We also see a negative effect on our graduates and on our health professionals. We see if there's not a positive team-based approach to care, we see poor transition to practice retention rates. I'm a nurse, so speaking from nursing, I know this is a huge problem for us. We lose 25% of new graduate nurses leave their job within that first year. We already have a huge shortage of nursing. We cannot afford not to retain these professionals. And that's just from nursing. I know it can be a problem in other professions also. We have high rates of burnout, even higher than they ever were because of the pandemic. These high rates of burnout from, not having a team atmosphere, not having a positive work environment, having too much stress, performing errors, and the negative effects that has on the person leads to burnout. And people either leave the profession, leave their job, or they have a negative outlook on their job, which affects the other staff, or all of those affect the other staff around them. And then we have to look at the health outcomes of our care providers. Yes, we want to improve health outcomes of all of our patients, our families, our communities. We can't forget the health outcome of our community of healthcare providers. Again, magnified so much worse due to the pandemic and the stress that all of our healthcare providers went through. But even before that, we've known for years that there is a high suicide rate among physicians, especially those in their residency. We finally have documentation coming out about the rate of suicide being higher in nurses than the general population. We're in a stressful profession, and we need to create positive team-based environments to work in. So we're going to just talk for a minute before we move on to IPE. Dr. Kulkarni and I wanted to share a video that we utilize in one of our classes to really stimulate discussion on why interprofessional teamwork is important, and especially why communication is so important. So I'm going to hit play here, and you should be able to see it and hear it.
Quarter socket. Quarter socket.
Quarter socket.
We'll need 2 of these, please. That ought to do it. Front driver's side. We ran a bunch of tests. The journal bearing is completely worn out from oil starvation. Connecting rods aren't sending enough oil up into the pistons to prevent them from overheating. Piston number 4 detonated inside the cell, cracking the block, and coolant is now leaking into the cylinder. I'm sorry. I need you to sign here.
So this is a video that, as Kelly mentioned, we share with our students, and it always stimulates a lot of great discussion and insights. But I'm wondering, we wanted to kind of discuss with you, like, what do you think of that video, and how it may be like a metaphor for what sometimes happens in healthcare? Like, what things did you notice in that video?
This is Patty McClellan. As a nurse, I mean, I could see like poor communication, both verbally and written. There was no team communication during tests. He seemed to be an assistant, didn't seem to be empowered to speak up when he saw something wrong. And those are just a few.
Yeah, great. Definitely. Like, so we noticed times in that where, you know, the lead mechanic was kind of mumbling, and it wasn't even clear that the the younger guy heard him or understood. Things were written down that weren't clear. Like, we noticed, like, the expression on his face doesn't seem like he seems like he's thinking of it. Has a question in his mind he wants to answer, but he doesn't ask that question. What other things did you guys pick up on in that metaphor?
This is Tisha Augustus. I'm also a nurse. Um, what I noticed was that yes, it must have been a lead, and there was a hierarchy between the two mechanics. And the one that felt like they were in charge, that could have been considered a manager, didn't really care about what the assistant had to say or what they thought, which is often a problem in healthcare. Even though the assistant may have just started or doesn't have as much years of experience, uh, his experience inside the classroom could provide a little bit more insight, because as we all know, healthcare always changes, and that new graduate could have some new information that the older person does not know,
Yeah,
or has not even taken the time to research any kind of evidence-based articles to keep up on healthcare trends. So
that is that. Yeah, that is such a great point, Tisha. It just not only, like, a trainee, what trainees can offer to an environment and new information, or just somebody with a different perspective can offer, like, and if there's that hierarchy that you mentioned, that information can't really flow into the care. Gabriella also noted that each person was doing their own thing, right? So the roles were really rigid, right? Like, and there wasn't coordination between those roles or good communication. I think that's an excellent point. Other thoughts?
My name is Gail Talford. I'm with the Mecklenburg County Health Department. And what I noticed was there was no feedback to find
Mm,
out, did someone understand what was being communicated, not only with the technician and his lead, but also with the owner.
yes.
Clearly tell he didn't get an opportunity to ask, did he even understand what was being communicated? That was that total look of, did you just speak to me in another language because I didn't understand?
Yes. Yeah.
That's a huge part of communication, which also leads to miscommunication.
Oh, that's such a great point, Gail. I think you're exactly right. And it's so, like, apparent, like, at the very end, when the mechanic is talking to the owner, right? He's speaking in a completely different language. And I think that's one thing Kelly and I have really learned in our, or even gotten better in, is that each of our professions has our own jargon, right? And acronyms and shorthands, and the way we communicate with each other within a profession might be really different than how other won't have meanings for other professions. And so it's really, that feedback is critical, right? Like, we have to make sure that we're communicating in a language that's accessible to different people, and that back to the issue of hierarchy, when someone doesn't understand, can they ask, right, for clarification? Do they feel empowered to do that? Is the person who's speaking and communicating also being sensitive to whether, and checking out that their meanings are received? Any other last thoughts before we move on that that video sparked for you? Maybe something that you see in your own work environment? Okay, well, great. Well, I'll turn it back to Kelly. I don't know, Kelly, if you have any last comments or if you want to just pick up the PowerPoint.
Yeah, I'll resume the PowerPoint. We use this video just to hammer home the importance of team communication, but also communication with our patients and family members in our communities. Like, the ball bearings are shot. I'm sorry. Like, imagine being that patient. And we just love this video because it reaches any learners that we have in the class, whether it's nursing, social work, public health, health administration, health psychology. Everyone can relate to it probably because most of us don't know mechanic stuff. So we have no idea what they're saying. But that's our patients and our families and communities. Sometimes we forget that what their experience is all about, that they don't know the things we're saying. And it really, to us, speaks to the importance of team communication and then clear communication with our patients, our families, our communities. Pretty sure that man in that video will never take his car back. Even his next one, he had a bad experience. And so
Yeah.
now we're going to miss opportunities to improve his car, aka family members, health in the future. So
Yeah, and just to last point when you were talking, Kelly, I was thinking too about just the lack of empathy, because the other thing we see with the car owner, as we do with patients and families, is the distress and the fear and the anxiety that's happening for that person. And then there's nobody really attending to that part of the experience.
And not thinking about what that person's life is at home and the social factors going on there and the ripple effect. Like, okay, I'm sorry, sign this, you're done. And that's what happens in healthcare. We transition to one setting to another. It's like, okay, you're off my hands, you're on their hands, and they'll figure it out. And I don't know. I love the video. I hope you all enjoyed it. I'm going to share my PowerPoint again. There we go. Okay, so the solution, or a solution to all of those issues that we just talked about, errors that abounded in that video, hierarchical issues, lack of communication, not developing sound relationships with the patient, family, community. A solution to that is IPE, interprofessional education. Infusing IPE into our work settings can not only prepare future professionals for the workforce, but it can actually also improve practice among current professionals. What was talked about before, the things that our new graduates bring us, that our students bring us, that maybe we didn't get. I didn't get IPE as a student. And so I learned it through what our students are going through. And that's how we can infuse more interprofessional collaboration into our work sites, by using IPE as a tool to prepare our future colleagues, but also to improve the practices that we all have in our own work settings. So interprofessional education is not new. The World Health Organization defined it in 2010 as when students from 2 or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. And that's really important, that they have to learn about each other, they have to learn from each other, but then they also have to be immersed in learning with each other. That way, when they graduate, they've already learned about other professions, they've learned how to deal with conflicts, they've learned all of those things to prepare them to effectively just carry right over and employ those skills in their work setting that they're going to be in. While IPE is not new. I mean, 2010 is not new, but it is still relatively new, considering we've all been educating our, students for hundreds of years, right? So it is a relatively new approach. Really, a catalyst started like in the larger universities with affiliations with medical centers and those things. And now it's really, really growing, and it's really required by all of our accrediting bodies that we do some sort of interprofessional education, because we know we have a problem in our settings with implementing team-based care. And we know it's affecting our patients, our populations. We know that it's affecting our healthcare providers. So we need to get people prepared to work in teams. And we just wanted to share this quote from a really great article that really kind of compares sports teams to healthcare teams. And in that first paragraph of the quote on your screen, you can see that sports teams have an advantage of coming together over and over and over to practice together, to the point where whoever's catching the ball doesn't even need to look back. They know it's coming to them. They know what their teammate's going to do. They know what to expect. They know how to work together. They are in harmony. In healthcare, the barrier is that these desperate people come together on any given day, any given shift, any given hour. They're expected to work together. They may have never worked together. They may not know each other well, and they may not have each other's backs the same way because they haven't developed that trust, that sense of team. And that's what we see in healthcare. I mean, I can raise my hand and say that's what I've seen. I can't tell you how many times I responded to a patient emergency, or I sat in on a team meeting and I didn't know the other people. I didn't trust them. I wasn't going to really speak up as much, you know? So we see this difference in how other teams are really trained, and we're missing that opportunity. We really need to train our students, our providers, really to work together so that when the time comes and that any given situation comes, they're ready to go. They can fall into place as a team. Very, very important. So this is our third poll, and we want to know how much IPE you might have had. When you were a student, how often did you have IPE, which is learning with, immersive learning with students from other professions? Okay, so the results are there. So about half of you never had IPE, and the other half had a rarely or a handful of time, with one person getting to experience it more often, which is excellent. But you can see there, we didn't have IPE. Depending on when you went to school, I know for sure I never learned with students from other professions. And the effect that it had on me when I got out there, I cannot tell you how scared I was to communicate with others. I have to call a doctor. I have to find the social worker and discuss a case. What are they going to say? Are they going to think I'm stupid because I don't know what I'm saying the right things or not? So not having those experiences definitely disadvantaged me. Did I overcome that? Sure, I did. It took practice, but how many times was the potential there for error because I was timid to approach somebody else or get the help that I needed or look at something from a different perspective instead of my own profession's perspective. So never having had it, that fits a great majority of us in healthcare who've been in healthcare for a while. We didn't get exposed to it. Our students now are getting more exposed to it, but we need to increase that more so that it diffuses over into our practice settings and it becomes the norm, not an opportunity for IPE, the norm of IPE, the norm to learn amongst other individuals. We're gonna do one last poll here, if it lets me. And we want to know if you're seeing IPE currently being implemented at your own work setting. All right, so kind of all over the place. Some of your settings don't have learners. Some settings only have learners from one profession. And then others have immersed learning, but some they're not learning working together. So kind of all over the place. And really what we're going to work on after I'm done presenting the overview is Shanti's really going to work with us to brainstorm ideas of how we can get IPE being implemented more as a method to improve our learner outcomes, to improve our staff outcomes at the settings, our provider, our professionals outcomes, and how to improve the outcomes of our patients, our families, and our communities. So just a little background on IPE. The left-hand diagram, that's from the Institute of Medicine. And what I really wanted to point out on this diagram was the learning continuum in the upper left, that our foundational, our pre-licensure education, we need IPE, but then in graduate education, we need even more IPE. And then in continuing professional development of our healthcare professionals that are already out there working, we need even more IPE. So, you know, oftentimes you'll hear IPE talked about for our pre-profession learners, but really it's envisioned to really start there, but grow and continue into the workforce to learn how to continue to improve our practices working together. Why? Because, you know, as you move forward with your career, your responsibilities grow. You start to lead teams. You do all of these things that requires even more ability to perform the interprofessional competencies. But also because the further you get removed from doing IPE in school, and we see this with our graduate student learners, there's a need to revisit and kind of get rid of the way that we've been doing it and go back and reimagine the way that it can be done, to unlearn some of maybe the bad habits that we might have picked up along the way. And then the other thing on this diagram on the left-hand side is the bottom left part, the learning outcomes. This is something that we're going to dive into a little bit more in our discussion, because most of the IPE assesses learners at the level of attitudes or knowledge about each other, attitudes working together. But what we really need to move for, to know that IPE is being effective, to know that practice change can happen, that patient outcomes can improve, is we need to really be able to assess behaviors and performance in clinical settings. But we really need to be able to move IPE into those settings to be able to do such a thing. And then the bottom right-hand diagram is the IPEC interprofessional collaboration competencies. And there's 4 core competencies that I'm going to dive into in a second. But I wanted to really point out that throughout all of those competencies is the need to be patient and family centered, as well as community and population oriented. So IPE really needs to be in settings where people work with patients, with families, but also where they can work with populations. And that's where the public health settings really come into play. So the first competency is values and ethics. And this is learning how to work with individuals of other professions, because we all have different codes of ethics. We all have different values. We all learn differently. We all learn things from the context of our profession. And then we need to learn to respect that other people have different viewpoints, and that's okay. And that's what this competency is about, is really learning how to work together, really learning to value each other's opinions and develop those trusting relationships, but definitely to put the patient and or population at the center of the team. We have to stop delivering care to these patients' populations, and we need to start collaborating with them as part of our team to help make sure the care best meets their needs. The second competency is roles and responsibilities. And Shanti talked about this, you know, that we all come into things with different skills, different communication, different words that we use, different things. We need to learn about each other's roles. We need to learn about each other's responsibilities. We need to know about role overlap. All of our responsibilities keep it, you know, expanding. And so role overlap's going to be, you know, it's going to happen. It can be very positive because a lot of people are trained to do the same thing, but it can also lead to conflict. So it's learning about each other's roles, learning how to navigate that role overlap, and learning how to pull different roles and put them together into a team that can best meet the care of the patient, whether that be medical needs, mental health, social needs, being able to find the right individuals to complement the care that needs to be provided. The third competency is communication practices with patients, families, communities, and other persons on the team. This is interesting. In a lot of our discussion in our course about IPE, there's a lot of talk from the students about what you should and should not say and how you should communicate. very little talk on how you should listen. And so we really need to emphasize that active listening is a core part of communicating. We can't just be telling others what's going on, telling others what to do, telling others our thought without encouraging them to share their own. And that's the only way we get to shared decision making, is if everybody has a voice on the team and they are encouraged to use that voice. So you'll see in part two, point two there, recognizing one's uniqueness, how your hierarchy or perceived hierarchy, your experience, your power, your culture, your gender, how all of those things can affect how you communicate and how others communicate to you, and whether it influences if they speak up to you or not, or they're scared to. And we really need to develop an understanding of that so that we can better encourage communication. This feeds into a point that was brought up before. It also includes providing feedback. Positive feedback for sure, we often leave that out, as well as constructive feedback and receiving that feedback as well. And then avoiding that jargon specific language as best we can, and clarifying it, looking at each other's face. Okay, I said a word they're not getting, let me clarify that, or they're comfortable to talk to me to clarify what I'm saying. It takes a while to develop that. When Shanti and I started working together, and we're peers, we worked together, she kept saying words, and I just remember thinking, oh my gosh, should I say something or not? And then eventually you say it, you get that practice, and you say, okay, I don't know, I do clinical experiences. What is this field? Like, where are you all? Just simple things like that. And now I'm comfortable to ask her things because I had that experience. So that's what IPE does. It gives you that comfort level. So then when you're out there, you're not timid to ask the questions. And then the fourth competency is teamwork and team-based practice. So relationship building values, principles of team dynamics. And this is to deliver and evaluate care as well as programs and policies. And it's really engaging other professionals in shared decision-making, shared problem solving. And that way you're all coming to a conclusion together of the best ways to proceed, less so delegating what needs to be done. And this is not to say delegation doesn't still need to be there, but more of a shared decision making and really being on it together. That's how people get invested, and we get new perspectives. And that's really how we move care forward, especially with the social determinants. This includes a lot of work on conflict resolution. We work on that a lot in our class. Conflict resolution, a lot of healthcare providers, especially from our two professions, tend to shy away from conflict. Well, most people don't love conflict, but more so sometimes we see it in nursing and in social work, not wanting to address conflict. But what we really try to get across is conflict can be good. It leads to new ideas, new ways of thinking about it, new ways of thinking about each other. But we do need to resolve it effectively. We cannot avoid it. So we teach them things from team steps, like the CUS acronym. I am concerned. This is unsafe. This is a safety issue. And, talking about that way, learning to address it in a way that I feel, instead of you're doing this. Learning to avoid confrontational behaviors and reserve that, really address that conflict in a positive way so the team can grow from it. So how do we master these competencies in our students, and then, also our healthcare providers that are already out there? The first step is interprofessional exposure, hearing each other's stories, learning examples, doing interviews of other professions, just learning about each other. And then we move to dialoguing with each other, where we explain our role. We have other people explain their role. We clarify things with each other. We compare, we contrast. And then we move into teamwork, where we can do case studies, group discussions, and we can even move into teamwork that is simulation based. And that's where most of the work that we've been doing in our online class focuses on. They are exposed, they dialogue, and they do teamwork because we filmed video simulations for them to plan the care of patients, families, and communities using these video simulations. We also do simulations in our laboratory setting. I'm involved in one for the Bachelor of Science in Nursing students, and they use telehealth, iPads, basically FaceTime, to reach out to other professionals to get their insight about how to care for a patient need. One of them needs respiratory therapy, another needs social work, and so forth. And so there's different ways to get that going, but we really need to move IPE more into community settings, more into practice settings, so that they can actually practice team-based care of patients and populations. And you can see that star there. Really, we want them to be able to practice complex team-based care, really learning how to address complex patients with issues with social determinants of health. And one thing that we have been involved in is something called healthcare hotspotting. And we do this with colleagues of ours from medicine, pharmacy, of course, nursing and social work, and I'm probably forgetting health psychology, several professions that we collaborate with at Atrium Health. And the small interprofessional student teams get these super utilizer patients that have frequent ER visits, frequent admissions, chronic diseases, multiple comorbidities, and social determinants that need to be addressed. And they work together and they address these things together in a team-based approach. They go visit the patient's home. They see what they need. Oh, they're not going to their visits. It's because they don't have transportation or whatever it may be. So we'd really love to see opportunities like that grow, where these students, they get so much value from really seeing how each other can contribute. And it just really makes a big difference in their learning. And our published results show improved patient outcomes from a utilization standpoint, less ED visits, more visits to their primary provider, and lower costs go with that. So we know that this involving our students in complex care in immersed team-based learning can really improve outcomes for our patients, for our communities, and we learn from it too. So we just continue to share new things. We just want to share from our class student feedback that just really stood out. It may seem easier or at least tempting to just do the work by yourself, which it does, right? We can all probably attest that. But it is worth the investment of time and patience to synergistically create a more well-rounded plan. And another wrote, collaborating on group projects showed the richness that sharing the work, not just dividing it up, can bring. And this requires coaching on our part. Mentorship throughout IPE is vital. We really need to, because their first inclination is, okay, there's 8 questions on this assignment. You take 1 and 2. I'll take 3 and 4. They'll take 5 and 6. And they divide it up that way. And when we get the work, we can totally tell, okay, this only came from a social work's point of view. This only came from nursing's point of view. This only came, you can tell where it's coming from. And then we just remind them, okay, now review each other's work, add to it, collaborate, do things together. And the products that come back, just so much more expansive, more comprehensive, and much more practical. You could tell it can really approach the problems that the group project was meant to design. So we really, really love those quotes the students brought forth. Whew. All right. I just have, I think, 2 more slides here, and then we're going to have some group discussion. Just the benefits of IPE. It benefits our learners. They get exposure to teamwork, team processes before they get out there and practice. They can refine their skills. And it also provides insight on other career options for those that might be going on to further their education. It benefits our clients, whatever our clients are. They have access to multiple disciplines, different ways of thinking, different approaches, different resources. They have a dedicated team. They get comprehensive care, and they get creative problem solving. Really infuses that creativity into what we can do. And it benefits our current healthcare professionals and the workplace, infusion of new ideas, new approaches, a renewed focus and passion for team-based care. And it can give recognition of mentoring benefits. So the value is clear. We know there's value to doing IPE. Why aren't we doing it more? One of the biggest barriers is in anything change. This is the way we've always done it. This is how we do it. This is what I went through, so you should do the same thing too. And we really need to move away from that focus. We really need to embrace new ways of doing it and recognize that, you know, what we learned, how we learned, yes, it was good, but maybe there's other things we can do that would make it even better. Other barriers are getting faculty and healthcare staff buy-in to work with our interprofessional learners. It can be time intensive for faculty, arranging large groups of different interprofessional students to come together, getting buy-in from staff, working with interprofessional learners, because it pushes you outside your comfort zone. It did for me, teaching social work students. I don't know social work. I mean, I know a lot of social workers and I've picked up some over the time, but it pushed me out of my comfort zone, mentoring them as well as my nursing students. And so it does, it pushes you out of your comfort zone, and you have to have buy-in for people wanting to do this, but it is so worth it. We have policies and procedures in place that inhibit IPE. Conflicting scheduling, that to me is one of the biggest ones. Oh, we'd love to do IPE, but we're only available on this day at this time. Well, my students are here at this day, this time. So we see a lot of confliction there. We also see it in our healthcare settings. We would love to send students to this clinic. Oh, well, it's only open on Tuesdays. Okay, so we can't do that. So we see scheduling issues. We have a need for logistical support, someone to help with this scheduling. It's not an easy feat. So having somebody to help with placing students, figuring out the settings where they can take more students, what professions, those types of things. And then lack of preceptors and mentors on site. Some of our disciplines require certain credentials, certain training from discipline specific mentors. So making sure that the site meets what we're required to do, that type of thing. The picture on the right hand of the screen, and we sent this out as a resource if you're interested in reading it in your fun time. This came out in 2019. To overcome these barriers, all of our health professions came together. Council on Social Work, American Association of Colleges of Nursing, all of them came together and developed guidance on IPE to show that it is coming from all of us. We can all work together to overcome these barriers. So we know that the advantages are there. We know that there are barriers. So what we want to work on now is figuring out how do we get IPE better going in our practice sites to benefit our learners and to benefit our healthcare professionals that are working there. And the quote, I'm going to end you with this, I'm going to turn it over to Dr. Kulkarni, but the quote in the upper right, if we are to have a stable, socially based, efficient, and safe health system, it is necessary for all of us, healthcare workers, policymakers, and educators, to implement IPE and collaboration at all levels of our healthcare system. It's vital to meet the needs of our complex patients, our complex problems in society. To address them, we really need to have an interprofessional approach. So I'm going to turn it over now to Shanti, who is going to facilitate discussion. I'm going to be taking notes while you all discuss. So I'm going to go ahead and mute myself. I think we had a chat. I'm sorry.
Yeah. I think it's let's see. What is the name of the IPE book? Do we have the link on the resources?
For the HPAC document with the guidance, they were sent out, so they're on the website, but I can try to find the links and put them in the chat while you all are going.
Okay.
I'm going to mute myself.
We'll get that to you. Okay, well, I want to thank Kelly because I think she did just such a fantastic job of covering like the landscape, right? So now I feel like you guys have a good sense of what's happening, with the field, like why IPE is important, how it's this big shift that we're grappling with. And we're just so excited to be having this conversation today because, we are in the university and we've been doing this IP, in the coursework of our learners and in other kind of initiatives that are going on. But we're really excited to get more of a footing is in the community. Like, so social workers have internships, nursing have preceptorships. All of our professional training programs have, a field experience where they're actually practicing. And when they can practice together in the field, that's a really it's magic. And that's been something I think Kelly just went through a lot of what the barriers are to making that happen. And so we're really excited to partner with you guys to think through, are there ways we can maybe advance this in our own community or think about this? So, anyway, what we want to talk about like how we want to break the approach to this down is sort of what we were provided with this framework that all of the other breakout groups are doing. So, and I forget, what is the first one, programs or policies? Or it's people. I know the middle one is people, okay. So people, so the way we want to think about it maybe is in terms of, who are the people that are involved? Is everybody at the table? I think when we're asking for change, we want to think about who's invested in change, who's excited about change, who wants, who's passionate, who are the champions, within organizations that want to get more involved in IPE. How do we identify them and kind of bring them in to collaboration with all of us? What are the processes, like as Kelly talked about with barriers, like what are the barriers that are getting in the way? I really want to have this kind of IP happening in my workspace, but there are a million reasons why that's hard and where I don't even know to start. And, we are in some ways trying to advance this practice in a system that's not built for it yet, right? So we're pushing the framework and we're pushing our institutions and we're pushing our settings, we think in the right direction and the direction that the whole field is moving, but it isn't easy. And so where are the leverage points that we can find so that we're creating processes that, advance what we'd like to see happen around IPE in the community? And then how do we know that we've gotten there? How do we know that we've achieved it? Right? Like in a way, we're talking about it in a general way, but how can we, I don't know, how can we communicate about it to people, right? How can we market it to people? How can we get people excited about, this is really going to help around social determinants of health, or this is really going to help around errors, or this is what it's going to, and this is what it's going to look like. How can we be a little more concrete in our language and our vision about what that kind of system will look like? How is it going to address health inequity, right? How can it be a tool to kind of address, racial disproportionality and outcomes, or, what are some things we can really use this team-based model and this IP to advance that we really care about? So I guess, why don't we, I guess I just want to open up the floor and maybe kind of, we don't have to have, I think what we'd like to do is when we leave, as we close down the session, we want to really have identified 3 priorities is what we've been tasked with that will advance these things. But we can go back to the other slide, Kelly, just to think, I just was foreshadowing, so we want to leave with that. But right now, maybe we can just kind of open the floor and problem solve, brainstorm, vision together. And then kind of as we get it all out there, let's kind of see if we can hone in together on some priorities that we want to present to our larger group. So so I invite anyone to share about, things that are successful, that are really working, about opportunities that you see, about barriers that you really need help in thinking through, and maybe you want to invite the group to help you think through how to push through any of that. So so any thoughts to get us started? So what about what's working? What do you see that's working?
So this is Patty McClellan from Charlotte AHEC. We provide programs for the healthcare professionals in our area and throughout the state. And we are in the process of developing a women's health series, and it's an interprofessional education model. It's a series, so it's 1 hour, kind of a lunch and learn concept. And we have a content expert talk about a certain problem within women's health, so stroke awareness. And then we also are hoping to incorporate subject matter experts on what are the available resources to underserved to help overcome those social determinants of health. So each month we're having a topic that we will present. So I think that some of the obstacles are, the recognition of, that we learn best from each other, and, that not just a physician is a subject matter expert, that there are nurses, social workers, counselors that are all experts as well. So I think that's a little bit of a hurdle to overcome in trying to help create recognition for that kind of program. I know it's not, we're looking at experts from acute care, primary care, and hoping to address, all members of the team and what they bring to that particular situation.
That's a great thought, Patty. So here you have this really innovative initiative, and to make it truly interprofessional, you want diverse people in your audience who are seeking the same kind of education and learning together. And you also want the people who are presenting, your content experts, to model
Right.
some of that team-based approach and that non-hierarchy and that, understanding. I think that's true. And it kind of illustrates that, we can even be siloed in that post-professional kind of training, right?
Yes.
We all
Yes.
go different places to get our CEUs or contact hours, for sure.
Right.
Yeah. Is that something other people see as a significant barrier? Or do other people have thoughts about how you've been able to overcome that? Because I think that modeling piece is important, right? Like, so I think about Kelly and I, and like what we, anything we do, we don't do alone, right? So even when we're teaching the course, if a student has a question, that's not something one of us answers without consulting the other person usually. Like, so it takes more time, and it takes kind of commitment to, for us to kind of engage in that and model that and live it.
I don't know that this is a barrier, but it kind of feeds off what Patty just said. And the offering that AHEC is going to be having that she just described, which is awesome. I kind of see people who gravitate towards these IPE, continuing professional education. They want IPE. They want to be part of a team. They want that team-based approach. And I think a barrier is, how do we reach everybody? Like, we have like people that don't want to do that. They attend a different continuing professional education, if that makes sense. So we tend to see the people like do it because they have an interest in it. How do we reach all? How do we infuse it more widespread? Like, and make sure that everybody knows about this, not just those of you who came to this meeting because you're interested in it. How do we make everybody?
Yeah, and it's almost it's interesting when you said that, Kelly, because it made me think, well, maybe it's like just assuming, like, whenever you do provide a presentation, that that this topic should be understood from a variety of perspectives, right? And it's not enough to have just one subject matter expert from one discipline to educate, that you really need multiple perspectives. But Patty, it sounds like that it's hard to pull those kind of things off.
I think so. I mean, I think it's a new thing for us. This series is a new thing. So I think really, what we've tried to do in meeting with the different speakers, the subject matter experts, is to help them understand that the participants will be a diverse group. They may be nurses, they may be, we're hoping some community health workers, physicians, PAs, nurse practitioners, all across the board, and that they hopefully will speak to that audience. And not speak above their heads in terms of, incidence and prevalence. And we also wanted them to bring into focus, this may be the incidence and prevalence throughout the country, but here in Charlotte, in the Charlotte area, this is what we're seeing, and how do we try as a group of professionals to overcome those barriers to health equity.
Yeah. Do you, Patty, when you do those kind of presentations, I was thinking about, how Kelly talked about, like, one of our values is around like having also people with lived experiences, whether that's patient or community members, to be part of that. Are those folks that get invited to panels or get invited, to share their expertise on these kinds of topics?
So we'll have our first session in May, and we're really kind of getting it off the ground, and I think that's a really good suggestion. And I don't know if 60 minutes is enough time for all of that. So, we're trying to spark the interest among, the different professional groups, and that sort of concept. So I think that is a wonderful, wonderful idea, case-based learning and learned experience. And, I think those are all great suggestions.
Yeah.
I think that's really interesting. I'm a student at UC Charlotte. My name is Chiamako Conquo. And although I'm not technically working within the professional field in terms of healthcare, I have had a couple roles in health education specific to HIV and STD. And so right now I'm working on a project and leading a civic engagement type project to develop an HIV and STD curriculum in Mecklenburg County. And something that I've kind of seen through that is trying to actually incorporate those lived experiences of individuals who are living with chronic STD, and trying to make sure that there is not a hierarchy as we create a review board that includes MDs, scholars here at the university, people who are working in research, people who have that lived experience, and trying to balance that. And of course, people come in with, preconceived notions about their own abilities and their own professional, background. And so trying to kind of break that down and create a level space has been interesting. And one of the barriers I feel like that comes with creating these interprofessional spaces. But I do think that I've had to see that more as I've gone through college. I think that is evolving. And I think that is becoming highlighted as something that is important. And I'm even seeing that in some of the curriculums that I plan to take on in medical school too. I'm going next year. And so I'm seeing those interprofessional experiences being incorporated into the classroom as well. So that's really exciting to see it happening more so and being structured in that way to kind of cultivate, that understanding of importance of these interprofessional experiences.
Yeah, I think that's so exciting that this new generation is coming up and already has that as a value, and is going to be bringing that to your professional work, and that you're getting some of that even in your training. Because like Kelly, I certainly didn't have those experiences.
I'm Tisha Augustus again. I'm a school nurse for Mecklenburg County Health Department, and I do work in a Title I school. I am also a graduate student as a nurse educator, and I'll be graduating this May. I've done several research papers on IPE, and I think that what I found in the evidence is that the buy-in of the older generation, it's what's the barrier. trying to get them to understand the importance of everybody working together for one common goal is difficult to get across. Although they will say we all want to do this common goal and we all want to help these children get what they need, but if they are approached with a question about something that may be for the nurse, say immunization, they'll say, that's not my job. I don't really do that. Let me transfer you to the nurse rather than walking the parent to me and staying there while we have the conversation of what immunization is needed to kind of try to learn like it's more like it's not my not my job, not my circus, not my monkey, so I'm not going to really do this, but here, let me pass you off to someone else. And I find that that's also difficult for the parent, and it always brings them added frustration when they get pushed off from one person to one person. So I think having other people, like Patty was saying, involved in these continuing education things so they can understand the importance and also the impact that it can make, even if it's not an inpatient, but on a parent just trying to get resources for immunization for their child in school. That frustration is heightened when they're passed on from person to person versus if we were all in this working IPE and in this common realm, we could answer questions for each other versus passing somebody off to another person.
That's such a great point. I think you're right that literature does show that it's such a barrier, like, you know, especially like within the hierarchy, like people, some people, not everybody, like, but some people really like hanging on to those old authorities or just like rigid kind of roles. I think, you know, I guess like I'm really interested to hear from the group, like how you break through some of that, because I guess like my passion for it, I think when people can make that like shift, that not only, like you said, Tisha, it is like definitely better on the receiving end as a patient or a family member, but also like it's a nicer way to work in general, right? Because you feel like you're part of something. You feel like it's not as stressful like when you're taking on everything yourself as that when you like are part of a team. Like we all know, I think Kelly covered that, right? Like that feeling of burden and responsibility that we might have can be alleviated somewhat if we're kind of doing this work as part of a group or a team. So I don't know if it's having people experience some of those benefits in some ways, or, you know, I'm just curious how people feel like they've gotten over that particular barrier where they've seen people like change either through education or experiences.
Dr. Kulkarni, I'm David Hainline. I'm Director of Innovation and Special Projects at Charlotte AHAC. And I just wanted to say that I think the elephant in the room on this, the whole topic really is resistance to change. And I think that the resistance to change comes in a couple of different forms. First of all, we've got problems with culture. And I personally, I mean, if I were going to pick one particular group to pick on, it would be physicians. I think they're having a very hard time adapting to all the changes in the last 10 years in healthcare anyhow. And in addition to that, there's just a general resistance to change because there is the entire healthcare system in the United States is in such a state of flux right now, and finance is one of the reasons why they're in flux. I mean, there are so many hospitals that are actually going out of business because reimbursement is not adequate to keep them in business. So the hospitals that are still in business are trying to figure out how do we do a great job taking care of patients and stay in business and deal with these what they consider substandard levels of reimbursement. So if you're going to make any changes in the healthcare paradigm, and that's really what IP is, it's a big change in the healthcare paradigm, you're going to have to figure out a way to make that actually make money for healthcare systems. And I think that means you have to have a dialogue with the payers, because that's the only way you're ever going to get any substantive change. that's what I saw in quality improvement. For years, I worked in hospitals and I sat on med-surg quality improvement teams, heard horror stories about patient care that would have been solved by actually going out and working with physicians to change their practice, but that never happened. Guess what happened? Medicare came out with an edict. We will not pay for the following kinds of misadventures in healthcare. Suddenly, hospitals are actually making changes in their quality improvement. And I think this is what's going to happen is that if the payers are going to insist on certain kinds of things being done, or maybe they'll incentivize certain things, they'll make money out of it because they'll have fewer problems with patients getting poor healthcare outcomes, and healthcare systems will make more money out of it. That's the ultimate thing that's going to tease out change, I'm afraid. Everybody else is just way too busy to even make great changes, and they're afraid of making substantive changes because the margins are small.
Yeah, well, I hear what you're saying, and I think that is already happening across the country. I know there are healthcare systems that are embracing these models of care based on like you mentioned, the bottom line, and that's happening at a lot at certain places. That's happening in other countries for sure. So I think you're right. It is going to take sort of the vision and the leadership to kind of promote that systems change for sure.
Well, if somebody within a healthcare organization can make an argument that it's going to actually be good for the bottom line, I think you'll actually hear people paying much more attention to the argument and potentially doing pilot projects. But if you can't make a financial argument, I'm just not sure how many organizations will want to make the change now.
Well, I wonder, to your point, like, I wonder if that's a big priority in our community, because there are those arguments to be made. And so I wonder if AHEC may be putting on like a summit, or, I mean, there are national people that are, driving this kind of innovation and showing those kind of cost benefits, and improved patient outcomes. It's definitely, the research is there to support that. So, so maybe it's kind of bringing that advocacy voice to the community, or highlighting it in some ways. What do other people think about? Is there a way to advance this argument? Is that a priority?
I'm on a statewide IPE committee that's headed by AHEC. And we've talked a lot about this, and a recent survey was done across the state, and the results should be coming out soon, showing the need for IPE and the reasons why and the supports needed. So hopefully we'll have more of these conversations. I think David's point about resistance to change and the need to inspire the change and talk about this more, and why we're doing IPE, not because we don't think what you're doing is good, but we can do things a little differently. And I think we just really, the word needs to get out more than, it is. That's my opinion. And I really, back to what Tisha was saying before, I really, I've worked with a lot of school nurses back for their, masters, and a lot of lack of interprofessional collaboration there. And the neat thing about that setting too is you have to know how to collaborate with teachers and security and people who are not in healthcare. So you have even more jargon to overcome and lessons to learn. And so I think there's potential for increasing IPE and collaboration in non-traditional health settings. It can't just only be practiced in the hospital setting when you round in the ICU. There has to be, it has to get out into our community settings too.
Absolutely. And I think from what you're saying, David, and from what Tisha's saying, and everybody really, it isn't an either or. Like, this really has to come from the top down and from the bottom up, right? Because I think we also know, like, things can come from edicts on high, and that can remove some barriers, but it doesn't mean it's going to change on the ground, right? So I think there has to be push in both ways. Another way I think the research is pretty compelling is that IP really helps with staff turnover, which is another cost for systems. And I think that's another. So I think there are a variety of arguments that can be made where there is a lot of evidence, and that are being made in other parts of the country and in other parts of the world. And so, if we want to see this change in our community, I think the people that are invested in that change need to think about how do we sort of change the dialogue around this, and how do we bring it from the top and from the bottom.
And I think too, when they were saying they were going to have the education, the workshop in May, I mean, push that out to the health department and to try to inspire them to send their school nurses. I mean, we have a 3-week lag between the time that the kids are out of school and the time that the school nurses are out of school. They get out the 21st, I believe, and we get out June the 15th. So we have time and availability to attend workshops like that so it can get out. I know that when I speak about it, I get, and not that it's a negative, but I get, oh, well, you're in school, you're learning about that. So of course you want to push it out, but it's more like, no, the evidence shows that it's beneficial for everyone, not just, again, like they were saying, not just in the traditional healthcare setting, but the reason why the schools have school nurses is to make sure that the children have some of the things that they need. So we as advocates need to be pushing for this and to help. And like you say, yeah, I have to deal with teachers and security and principals and guidance counselors and the social workers that are within the school and registrar and all of that. So all of us could get together to make that one smooth transition for kids who do have healthcare problems in school, but also just period, just to help with that equity. Because we all know that if you're hungry, if you're thirsty, if you don't have good shoes on your feet and there's no heat at the house, you don't care about Christopher Columbus selling the ocean blue. You want to eat. You want to have shoes on your feet. You want to get warm. So it covers the whole perspective of equity, healthcare, and just personal needs to be successful.
Yeah, I think that's really well said. Really well said. Um, and another thing I wanted to pose out to some of you is around, I'm just, from what all of you are thinking, it just reinforces, I think, what we all know, which is everybody is so busy, and this pandemic, I think, has only heightened that, right? That sense about like, I'm just barely kind of hanging in to do my job. And so, when Kelly and I approach people about taking on students, it's hard, right? Because we're asking them to often do more than their job, right? To take on something additional. And we know how important and transformative those experiences can be, not just for the student, but often for preceptors and mentors, right? Like I think someone said earlier about how students can bring innovation and new ideas and all of this. But if you're part of a system where training isn't really recognized as something important that you do, like where you don't either have time that's allocated for it or recognition, or that, it doesn't show up as valuable, that it's really hard. And so I would really love to hear from you all your thoughts about, do you feel like training is an important part of the mission where you are? And if not, are there, do you have thoughts about that? Like how that could be kind of highlighted within your organization?
This is Gail Talford from the health department. I can honestly say that within the past couple of years, when it felt as though we were about to have a mass exodus due to retirement, um, training really became more heightened, if you will. And the fact that we needed to make sure that we were considering succession planning, and to no better way than to make sure that those students, obviously we're going to be a part of that, because having those students who are interested in public health to carry on the torch, if you will, but making sure that they got in, right at the very beginning or the grassroots, and they got the experience from those who had the most experience, was going to be beneficial, and to give them that experience. And I'm not saying that it wasn't on their hearts and minds before. I'm saying that it really became heightened at that point when we began to see a large transition of those who were leaving, because we always knew that, number one, nurses would leave the profession at one day. We don't always work past 40 years. I'm personally in my 33rd year, and I mean, the time flew. I didn't realize, it's gone. It's already come and gone. And I don't see retirement in my, near future, but it's going to come at some point, because I do love what I do. But, we also have to consider those who are going to have to take care of those who will come after. So now we think about it more often, and we think about those students. And I've always been a big proponent of education. That's where I went with my master's degree for education, and wanted to make sure that I pushed education. I love to see preceptorships and students that are getting that additional learning, because I know for a fact that that's the only way that the world is going to continue to turn. If we don't do it, then everything's going to come to a screeching halt. And we think the pandemic is bad. What will happen if we have a pandemic and we have no nurses, no social workers, no people who will carry on? We will be worse than COVID-19. Trust me. So
That's a really scary vision, Gail.
yes.
Yeah. Well, can I ask you a little bit about what do you think was successful about what your department did about like shifting a focus to bringing in, have training more of your job to bring that in? What worked about making that a bigger part of what you were doing?
I think making sure that we, number one, we didn't forget those students. When we had a big transition of our director of nursing, who was there for about 40 years, who left, and for a brief period, we didn't have a director of nursing, and they opted to bring a director of nursing back. That was huge, because having someone who really understands nursing at that helm, and is really a big proponent of education, also understands the importance of that nursing education and that nursing preceptorship and nursing as a continuum for the students coming in and learning, and those students actually liking to work there, or what the experience was there, to want to come back and work at public health. So it makes a huge difference. So I think that's where we've begun to really see how beneficial it is, more so now than ever. And like I said, while it may have been a focus before, I know it's more of a focus now, because we do have students that have opportunities to go wherever they wish to go. Nursing is so vast, and you can choose to do whatever you wish to do. But public health is a specialty, in my opinion. And just in general, it involves a person who really likes to do work with the community, because it definitely takes a strong person to work with the whole COVID realm, even if you're in the healthcare setting, or if you're actually out in the community setting. So I think that had a lot to do with it. Just getting that director of nursing, somebody who really understands nursing, and just is a big, has a big push for nursing and education, and really understands that. So I think that helped a lot.
That is really so helpful. So I heard a couple things. One is just like having your leader really value training and bring that in, but also that what you're saying that seems so important is, a recognition that this is a workforce pipeline. And that you need to take care of it. It's not just that you post a job, right, and wait for people to apply, but that if you're part of that training, that future workforce, that you have a better chance of, like, you're feeding your own organization, right? And that and I think to David's point, then there's that cost kind of financial argument to be made in that realm as well, like what that saves in terms of that you have a really qualified pool of people who know what they're getting into and that are passionate about it and that want to do that work and can do that work well.
It's nothing more satisfying than to see an individual who comes through an internship or preceptorship who really says that they enjoy it and that they got a lot out of their experience and that they have a desire to come back and work in that area when they graduate. I think that's probably paramount to anything else, honestly.
Well, do you think, and I don't want to just pick on you, maybe other people who've had the experience of being a preceptor, like how does that affect how you do your job, or how you are there some benefits in doing that for you?
I've actually, fortunately for me, I've worked in public health and I've worked in the hospital setting. And when I was in the hospital setting, I have actually seen someone go from a nursing assistant to a DNP when I was a manager in the hospital. So I've watched them grow from that point to now a DNP in a university. And I cannot tell you how satisfying it is for me. I'm still proud to this day because that individual mentions the fact that, I used to be very much on them as far as learning and encouraging and telling them what they could do and not to give up. And today they are at a university teaching. And it's really, to me, it's a good feeling for me. So I guess I just kept wanting to do that. I wanted to keep fostering that, that type of um, energy. Every time I saw someone willing to learn, it just gave me that thrill to want to help them. Because I certainly hope that there'll be someone to care for me at some point in my life. My daughter chose not to be a nurse, so it's gonna have to, someone is gonna have to take care of me at some point. So I get a personal goodness, if you will, out of it. I mean, it's for me, it's very rewarding to see that.
Yeah.
It really is.
Yeah, thank you. Have other people had similar experiences, or
So I one of my colleagues, she just got her doctorate and she has been precepting a young woman, and I've actually helped her with some of the projects that the young woman was doing on the black light detective and her working on some personal research. And it's just even collaborating with her to help this young woman who's been trying to get this information and work on data. Even if I don't have a full hand in it, just a little hand in it, but watching her work with this young woman and, really pushing her even when she wanted to give up, and encouraging her not to, that she could do it. It was just, like I say, even the collaboration was worth it, just to help.
that is so awesome. Well, I am noticing we have about 15 minutes, and sort of at the end of that time, we want to have some priorities done. So Kelly, do you think maybe we could switch slides and maybe collaboratively we could think about what do we want to say in our report out? Do you want to can you summarize, and I'll kind of chime in about what were some of the major themes that you heard, or maybe some possible priorities?
Sure. Some of the themes that were brought up that I captured, you all tell me if I'm right or not, but some of the themes that I heard was the need to change the way it is, and the need to spread the word about IPE, if I will, to get people more interested in it, to get people to, change doesn't happen overnight. This is a big shock to some people, especially if you've been in practice and you're far removed from IPE in school. So really exposure to what IPE is about, exposure to the benefits of it, exposure to ways that it can be accomplished. Things, having lunch and learns, bringing people together, getting it started, getting it going, very important. There was also talk about the need to make it clear why there are financial benefits. I kept thinking of the triple aim when this was being talked about, that cost effectiveness is key. We all know that if you want something in healthcare, you have to show why it'll boil down cost wise, and there's almost always a way to show it will boil down cost wise. But the fact of the matter is, there's really not a billing mechanism for team-based meetings and doing these things. So until there's better diffusion of cost recognition, it's going to continue to be a barrier, and inspiring people to see, you know, I don't know the words, but like you
Yeah.
think of errors and how costly they are, missing that, addressing the social factors, to me, that's an error. Like you've missed something that could change a health outcome.
Yeah.
So
And I
talking about
think that
that.
to your point, like the triple aim does like look at cost, but it also looks at quality, and it looks at I can't remember what the third one is. And then there's a fourth one too that really has to do with workforce wellness, right? So I think
Right.
that might be a framework. I don't know what other people think. I also wanted to recognize Tisha mentioned buy-in from leadership, and I think that might be an important one. And I think also from Tisha and talking about school-based services, to me that says we need to expand some of our definitions of what healthcare is and who are on these teams, because especially when we're addressing social determinants of health, it might not be in a traditional kind of healthcare setting.
Absolutely. I that stood out loud and clear. And from my own personal experiences working with students who are in school health, who are in prison health, who are in all of these settings, where autonomy is very valued and you work on your own a lot, it's even harder to pull the team together. I've heard really bad stories about school nurses saying they were left out of IEP meetings, and their input wasn't valued, and it wasn't brought up to them that the patient was on insulin, or just all of these things that the team needs to recognize each other and come together in alternative settings too, and expanding our thought, like you said, Shanti, about health settings would probably provide more places for our students to learn, and better enrollment into these settings post graduation, like recruitment.
Yeah, and even I mean, we're getting really broad, but maybe like bringing other professions that normally, like to have med students like see what a school nurse does, you know what I mean? Like, I mean, there are all sorts of possibility, and yet we are really constrained by you know, some of it is vision and some of it is motivation, like, and all of our, you know, they're based on a lot of the barriers that people have brought up. So I'm trying to think of how we can, like, I wonder if people will chime in and say what they think maybe a big priority, because what is it we have to, what do we have to do with the 3 priorities?
Priority, we can come up with strategies and needs. I think, you know, addressing priorities is key.
So maybe flip back to so maybe we can take a stab at like identifying what some of the priorities are, because there are lots of ways to do it. But I heard one about this leadership buy-in thing, and part of it was about the financial argument, and then part of it is maybe broader than that, you know, maybe about training or information. But do people think that, does that hang together as leadership? What are your thoughts, David? I know you kind of framed it as more of a financial payer kind of thing, but do you think it fits within, that could be a strategy under leadership buy-in?
Well, I mean, I think the thing is that leadership, it's going to depend on the leadership. I mean, you know, ultimately you've got to make a value proposition to leadership in whatever organization, whether it's an individual, you know, primary care practice, or you're talking about a multi-hospital system. So I think the thing is that I have no doubt that for example, the big healthcare systems, they like the idea of IPE. I'm sure that they would think this is great. The problem is when you have a stack of priorities that you're trying to implement, making it to the top of the heap is always difficult. And if you've ever had this situation in a job trying to get to the top of the heap, sometimes you've got to pile on arguments for something.
Yes, absolutely.
And so it's like I'm saying, it's not just, there's some cultural things to overcome. There's inertia, there's just resistance to change. There's lots of stuff.
Right.
And I think the more things that you can add to that value argument, the better. I really honestly, I can't believe anybody who's heading a healthcare system wouldn't immediately see the good reasons why you want to do this. It's just that it is a sea change. It is a paradigm shift. And even if you start doing this as like projects, test projects and stuff like that, you're starting to stir the pot. So you want to give them as many reasons to say, this is good for our patients and it's good for business.
Yeah, absolutely. And to your point, some of it is, I mean, if it just comes out as a mandate and there aren't like resources accompanying it, like in terms of how people practice, right? Like workflows may have to change. There may need to be new positions to support different, that to round out like a team, right? And so it's not, you're right, it's not just, it's accompanying the resources for people to do it rather than just telling them, now we're going to do team-based care. Now
Well, healthcare finance right now is a house of cards anyhow during the pandemic. And I honestly think if you can't demonstrate a really solid financial return on something and not just a theoretical thing, then I think you're more than likely going to get somebody say, this sounds really good. Let's revisit this in 6 months, a year, or whatever. And it may be in a perpetual holding pen in some organizations, because not that they don't think it's a great idea. There are a lot of great ideas about improving healthcare out there. It's where does the money come to make it possible?
Yeah, absolutely. So I
Could
think
this is Patty. And I don't know if this has been discussed. I had to step away for a couple of minutes, but I think that in order to bring people to the table, I think you have to first understand why are they so resistant, and that may have been some discussion that's already been had. So and I see the greatest resistance from physicians, as someone had alluded to earlier. Maybe it was you, David. But I think that in my experience working in primary care area as a quality a performance improvement coordinator, despite leadership buy-in, there's a lot of pushback. And why is that? I think that the physicians and advanced practice providers are stretched to the max. And I think that they haven't taken the time to understand the function of different roles and how we can leverage their highest level of licensure to take some of the load off from them. So I think that bringing people to the table initially and discussing like why are they resistant to this, and someone who really and I think building trust, I think, is another piece of that. Do you trust this person to take on that role for you? I think those are all things, understanding and trust. And I think those are some beginning steps. And, in light of what's going on in the world right now, I think that it is even more difficult. But I think that, to hold those sort of at a state level, at a local level, those conversations and those discussions.
Yeah, I totally agree with you, Patty. One of the problems, and I can't tell you that physicians in Charlotte today have the same attitudes, but I remember a conversation I had with a doctor years ago that I was explaining why we were moving. This is back with paper medical records. I was explaining why we were going into integrated progress notes, where all the allied health professions and the nurses and physicians all be writing on the same progress notes so they'd actually know what each other was doing. And this particular physician summed it up this way. He said, I do not want physicians' notes covered up by a bunch of pot scrubbers and dishwashers. And it was that plan to go to multidisciplinary progress notes was undone. And I think the thing is that part of that, it goes back to trust, just like you say.
And respect. And respect.
But those kinds of attitudes, I thought would never change in some of the things that threaten patient safety. But boy, oh boy, when Medicare came out there and said, we are not going to pay for this anymore. And of course, Blue Cross and all the others followed, said, me too. Boy, things changed.
And I think also in some of the places that I have worked, other than in the Charlotte area, I think one of the things that is an impetus for change in IPE is a really messy sentinel event, a big error in a system, and that brings people together. I mean, that speaks very, very loudly. And not that you want that to happen, but I to bring about the change, but I think that we can learn from illustrating those huge errors that could have been overcome, in like the video you showed us earlier.
I'd like to add in there too that maybe it doesn't just have to be an error, but could we capitalize on the leading on opportunity report as our error? Like,
yes,
this is a problem. If we had all these specialties come
yes,
together in this way or that way, we could have prevented being
yes,
last on the list, and we can move away from it, or I don't know.
that's a really good point.
Yeah, and so maybe it's kind of integrating like this interprofessional approach as a solution when these sentinel events occur, or when we have a community crisis, to like use that lens to look at as like these problems are too difficult for any one group to kind of address on their own, and for any group to address without input from the community and the input from people who were affected. And so how to, that's what a team-based approach is. And so,
yes,
yeah, it's, yeah, so I guess that has to do with sort of, yeah, just more really widespread education, right? And it really changing like the way we think about our approaches and implicate the current approaches in some of the current problems.
Well, maybe one of the things you folks might want to consider is going to their leadership, their organization, and say, hey, can we try a pilot project in a special area, and here are all the reasons why it might help. These are the metrics we're going to track, and then do it just in that one area, and then make sure that you very carefully quantify what the benefits are, and then follow up on it and demonstrate through pilot projects. And then maybe what you're going to do is you eat the elephant one spoonful at a time. You do more and more pilot projects, and until suddenly we're all doing the same thing.
Yeah,
that also kind of makes me think about pilot sites too. Maybe instead of, we want this everywhere. We love IPE. We want it everywhere. Everyone should be doing it, but maybe we need to start at a model site or two or something and show the benefits. Like maybe they have improved recruitment, improved retention, improved outcomes, those metrics that David was just talking about, whatever metrics work for the site. Yeah. So maybe identifying model sites that would like to be an IPE leader and really like building it up there. I also, going back to what Gail was talking about before about that intrinsic benefits you get from teaching, mentoring, precepting, whatever you want to call it. I think also adding to that some sort of recognition, internal, intrinsic, like, I feel good stuff is great. And we love that. But we also, I think, need to do a better job of recognizing the work and expertise that our preceptors and mentors go through, even certificates, something to put on their resume that shows how awesome they are and that they are valued, so that they want to keep doing the great work they're doing.
Yeah, I know we work in our program with a more like a rural, like federally qualified healthcare center system. And like one of the things they do, it's actually part of their leadership development, is they take on a student and they get an extra $100 a month. And they it goes into their performance evaluation, right? And so those kind of things, like, I mean, it's really communicating this is what the organization values, like this is visible, right? It's not, I think a lot of times when people take on a student, it's just something extra to do and it's not visible. It doesn't, maybe you're a wonderful person like Gail, and it just like, it gives you that good feeling, and that's the most important thing. But like, it should be more than that, like Kelly was saying, like be really something that's valued by what, the service they're providing for their organization, for the profession, for the community. It's huge. So back to, I'm just a little, I think we're probably at time. I'm just a little concerned about the report out piece. I feel like we have enough content. Do you, unfortunately, I'm not going to be at the 2:00 session, but would you guys feel okay if we kind of like take some of the, highlight some of the themes and contexts and strategies and then present it on the behalf of the group, and then allow you guys to kind of chime in that discussion if we've missed something, or if you have,
Sure.
yeah, I mean, that's the best way I can think to do it, just given the limited time. But if somebody else has a better idea. So some of the broad things I'm hearing about are, making change from the top down and from the bottom up, like really engaging people who are passionate and want to do the work, identifying pilot sites, like Kelly said, and other people said, like David also mentioned, where we can really do proof of concept and really have kind of data rich kind of arguments for, rolling this out more widespread. I think looking to national models, right? Like that communities are already doing this. We're a little bit behind actually. And so bringing that to our community as part of, our advocacy on behalf of IP. So those are the main
One
things.
thing that would really make us stick out too is if we chose a model site that's maybe non-traditional, and show that it can work in community-based settings. And that it doesn't just, like I brought up before, the best example that I've ever seen of IP is like interprofessional rounds at the bedside and in acute care settings. But and there's a lot of evidence on that, but it would be really cool if we proved, hey, you bring a team of students into a school setting, look what can be done, look at these metrics, look at the rates of immunization or whatever it is that you're trying to accomplish there. It would give our students a lot of learning.
Yeah. And if people want to talk to Kelly and me about like developing those pilots, we're really ready and open to do that. I met the HRSA grant, the training grant that we have that I mentioned at the beginning. We're going into year 5 of a no cost extension, but we've also applied for renewal. So we're waiting to hear that like in May and then July, but fingers crossed. And if we get this renewal, one of the things that I wrote into it this time around was to really have a community work group around IP, around, a lot of these issues we're talking about. And Kelly would lead that. And so I think that would be another opportunity. And you folks who took the time and selected this topic as the one you wanted to be in, would certainly be people we'd love to engage and, just furthering these discussions. And because a pilot like that, I mean, really, if we have a passionate school nurse, if we have a social worker at that same school that wants to do it, right? Like that might not take a lot to just pull that together, right? It just takes people like who are champions where they are to pull that together. So any last thoughts, or I guess particularly around the report back, is there something you really that we haven't mentioned that you think would be really important to bring out for the larger group? Well, you guys have been awesome.